So thank you very much for joining us. Just a quick housekeeping rules. As ever, this is recorded. You can rename yourself, mute yourself unless you're speaking, and later on, raise your hand if you want to say something. And as said, be respectful of everybody's opinion. So I hand over to Louise Arnold, Advanced Nurse Practitioner from the PNH National Service in Leeds, who will take us through the presentation for today. And we'll also have Dr. Richard Kelly, Dr. Maura Griffin, and Dr. Matthew Holt later on.
So thank you, Sophie, for that introduction. So my name's Louise Arnold. For those of you who don't know me, I'm a haematology nurse by background who've been involved in bone marrow failures over the last 20 odd years, and have a particular interest in PNH and aplastic anemia. So we thought it was important today to mark Rare Disease Day, and it's lovely to see so many of you on the call today. So we were thinking about what's important about rare disease today and why it should be marked. And there are over 3.5 million people in the UK living with a rare condition, and that's about 1 in 17 people. So collectively, a rare disease can become quite common in that way. So being marked all over the world by different ways and different things, the Genetic Alliance, as we heard earlier, is having a parliamentary reception this afternoon. And people have been wearing colour to mark it, as I showed my trainers just now, if you were here early enough. There's fundraising going on, and I've seen lots across the board. And loads of sharing on social media, a campaign on by Eurodis, the Rare Disease Europe group, who are lighting up buildings across Europe. And here we focus on the slide here, I was focusing on the groups that were involved in the Super Rare campaign, that's to promote not being alone. And as some of you will be aware of, the PNH support has been a big part of that, along with Aplastic Anemia Trust, the Congenital Anemia Network, the Keratosis Congenita Action Group, and Fanconi Anemia Hope Group, and the Schwartz-Diamond Syndrome Group alongside PNH support. So by bringing attention to all of this, that's just a small part of rare disease of the many, many people that are out there. But I think it's important to focus on some different things that come from that. And when I was reflecting on it myself, it's how do we improve, how do we support, and what do we do that makes it so important to note today? So the areas of focus in my mind, we're thinking about support. So we all have to support each other. And I think more importantly than anything, it's supporting someone with a diagnosis of a rare condition such as PNH. And in my mind, the most important thing is that we treat and manage the symptoms, yes, but I think the support and the ongoing support around that over time is important, as well as supporting each other as healthcare professionals to get that right within management and disease management. Whilst also I know that Richard, Morag and Matt are all going to talk about research, I think research has always been key in understanding where we've got to. And I think it's reflecting on how we've got to where we are today in the world of PNH, particularly from when a paper was published in 1993 suggesting that the reason for the problems that causes the symptoms of PNH, with the GPI anchor being missing, so making the blood cells different, to then nearly 10 years later of the start of clinical trials for complement inhibition, which has become more of a mainstay today, and we're more understanding of for those with the diagnosis of PNH that do require treatment. So I'd like to reflect on that in a sense of how much change there's been from that first approval of the clinical trial of a pilot study in 2002, and the first patient receiving a complement inhibitor in May 2002, not even 20, to then in 2004 when we had the pivotal study with Triumph, where there was patients on a placebo compared to treatment, and we're sat in the room together and discussing it and understanding it, to now where we are with the national service with many different treatment options, and the moving forward of that across the world with the sharing of information. And that comes very much in the hands with increasing awareness and aim to increase understanding and knowledge. And days like this will assist that, but also the ongoing nature of that and making sure that there is education ongoing, whether that's in clinic and understanding to other healthcare professionals that may be involved in care around diagnosis that's rare. And I think all of those are so valuable alongside treatments. And treatments, I know Dr. Griffin's going to talk about treatments in depth in a moment, but I think treatments have come a long way. But I think it's also around how we manage treatment and how we improve it, but also get it right for the right individual. And it is so individual, particularly in rare diseases. And in that, my final thought was about solidarity and how we do this together. And it is a partnership and working very much together in that way. So I think Rare Disease Day brings that all together, and I thought it was important to organise something today to just mark that, which was the result of this meeting today. But I think it's important to hear a little bit more detail around research and the registry and different things that are going on from our side. But Dr. Griffin is going to have a little chat now, or a big chat, around all that we've achieved over recently. But I think also that is achieved as a group collective. I don't mean as a national service, I mean as people with a diagnosis as well. So if we move on to the next slide.
Yeah.
I will hand over to Dr. Griffin and I will let her introduce herself.
Thank you very much. Thank you. It's very, very nice to see all of you online today, and happy Rare Disease Day. I think, as Louise said, we've come a very long way. So we thought we'd keep slides to the minimum, but in 2023, we've had various updates, and we thought I would just cover them a little bit. So I'm sure many of you have seen on our website, many thanks to the donations to the PNH Charitable Fund, we've developed a video explaining what PNH is. So many of you will have attended clinic and seen on a bit of paper us drawing squiggly diagrams with variable handwriting. So this just translates into our handwriting into a much more slick explanatory video. Louise and I were honoured to go to the European Parliament last year to represent PNH within a rare disease meeting that was undertaken at the European Parliament, and so we were honoured to do that. We managed to have our first IPIG, so the International PNH Interest Group, the first ever conference was undertaken in Harrogate, and as you can see, we took the opportunity to take a photograph of the majority of the Leeds and Kings team, and as you can see, we've grown quite significantly from when we first started, and there are still some people missing from this photograph. And we were thwarted by train strikes, but we managed a Zoom PNH conference for patients and families in March 2023. So thanks to COVID, to updating our IT skills, but not thanks to the train strike, we couldn't meet in person. And then this is Dr. Pike presenting one of our her research at the American conference that was done in December in San Diego. And I'm sure you're aware, many of us presented a variety of different abstracts and updated information at that conference. So moving on to treatments. Who did we see and who did we treat? So yes, sorry, next slide, please. Just for information, really, PNH is a rare disease, but as you can see by the number of you online and the number of patients that we actually see, we saw 666 patients within the service, and not only about a third of people are actually on treatment for PNH, and for the rest of the people we're monitoring closely. And we thought it might be interesting to show you what indications for treatment people have. Obviously, treatment is prescribed for specific groups who have indications for treatment, but the majority of patients were for hemolytic PNH. So if you started treatment in the 2022 to 2023, you will recognise one of your indications for treatment within this group. And we had one pregnant lady. supported with eculizumab during that time. We currently have no pregnant ladies. We've had everyone delivered, so I'm sure there'll be a few more. So moving on to treatment options. We've moved from, I can have the next slide, please. Eculizumab being the only treatment available, and many of you will have seen, I've presented this diagram presented by Dr. Pike before, but actually there's additional treatments been added to this since I last did a patient group meeting. And we'll notice at the level of C5 inhibitors, eculizumab and ravulizumab, established treatments for PNH, pozelimab, and on the left-hand side, cemdisiran, again, blocking at the C5 level. And we have some patients on that combination as well, but post-clinical trials, so it's not currently approved for general treatment. And then if you move up the complement cascade up to C3, going up the diagram, pegcetacoplan, many people, we've got about 22 patients now on pegcetacoplan. So that is for patients who are anemic symptomatically on eculizumab or ravulizumab, who would like to try and address the anemia with a subcutaneous self-administered treatment. So self-administering subcutaneous infusions is not for everybody, but for the 22 patients that we have on treatment, the majority are doing well with that, and that's twice a week treatment. And then if I take you up the alternative pathway on the right-hand side, we've got some tablet treatments that you may well be familiar with. So iptacopan is a factor B inhibitor. It's a tablet twice a day. Some of you on the call will be on that. And danicopan is a factor D inhibitor, which is an add-on treatment to ravulizumab or eculizumab. And again, some people are on the call probably on that. So these are within clinical trials at the moment. Iptacopan and danicopan are being assessed, as I'm sure many of you are aware, in April by NICE. So we'll need to await the outcome for that. And then you'll notice there's MASP inhibitors. OMS 906 is in here. It blocks the production of factor D. And we've got a clinical trial. We were the highest recruiters to the clinical trial, the phase 1 trial. So we've got 8 patients within that study at the moment. So that's quite an early phase treatment option at the moment. You'll notice missing from this diagram, and some of you will have had letters, we've got biosimilars that are now approved within the UK. So a biosimilar is a drug which has been produced, which is essentially a sort of carbon copy of the original eculizumab. There's 2 different biosimilars now approved for use in the UK, only for eculizumab. So patients who are on eculizumab will if you haven't received the letter, you'll be receiving a letter about the consideration to switch over to a biosimilar or one of the other products that we currently have available on the NHS. So there has been a move with a biosimilar study. It's proved efficacy and equivalency to eculizumab. It's just made by a different company. So I know there are a few queries sent in about biosimilars. So we've come a long way. We have a lot of progress to go, and I'm sure within time this diagram will be updated by Dr. Pike, who has the computer package to do so, with additional products being put on there. So we strive continuously to make improvements for patients. We wouldn't have got anywhere near this developed diagram without your input and your support and your willingness to trust us and to go on to clinical trials. So I would say we definitely thank all of you for assisting in this as well. So if we go to the next slide, where are we going in 2024? As I said, iptacopan and danicopan are being assessed by NICE in April, so we'll await the outcome for that. We continue to attend conferences, present at conferences, educating and updating healthcare professionals about PNH, and the patient support groups are also represented at these conferences. And international PNH interest group guidelines are in process and in progress at the moment. So a variety of us are contributing to those. So thank you. I think there might be an option for questions at the end, but if anyone's got any burning questions, I could take 1 or 2 now before we move on. Okay.
I think we might do
questions at the end. No problem. I think I'm handing on to Matt, possibly. So thank you.
Absolutely. Thank you very much.
Thank you. Nice to meet everybody. Thank you so much for allowing me to talk to you today about my research, which is revolving around breakthrough hemolysis in PNH. Thanks. So who am I? So up until last October, I was a haematology registrar. I've worked in Leeds and West Yorkshire since 2018. But as of October, I became a clinical research fellow, which means I've come out of training for 3 years. I am employed by the University of Leeds, and I have an honorary contract with the NHS, which allows me to work alongside the the National PNH Service to do a 3-year PhD, as I say, looking into the causes of breakthrough hemolysis in PNH. My project is funded by Sobi. They are an international biopharmaceutical company based out of Sweden, and they have the commercial license for pegcetacoplan outside of the USA. Next slide, please. My research, as I said, is about breakthrough hemolysis. So the first question is, what is breakthrough hemolysis? This is when patients with PNH redevelop signs or symptoms of intravascular hemolysis despite being treated by a complement inhibitor. And when you look at the blood tests, it's associated with a raised LDH. Many of these symptoms you'll be aware of, but they include fatigue, hemoglobin in the urine, so dark coloured urine, pain in the tummy, breathlessness, anemia when we do the blood tests, blood clots, difficulty swallowing, and erectile dysfunction in men. So when these symptoms redevelop, when a patient's receiving treatment, we are suspicious for breakthrough hemolysis. Next slide, please. How common is it? In the Alexion 1210 trial, where they compared ravulizumab and eculizumab, the incidence was anywhere up to about 11%, really. It was 10.7%. I've just got the data next to me. There were 2 studies. In the first study, there was about 125 patients on ravulizumab, and 5 of those patients developed breakthrough hemolysis. So that's about 4%. Whilst on eculizumab, about 13 patients out of 121, that's the 10.7%, developed breakthrough hemolysis. In the second study, patients on ravulizumab, just under 100 patients, and none of them got breakthrough hemolysis, whereas with the eculizumab, it was about 100 patients again, and 5% got breakthrough hemolysis. So it's variable, but it's anywhere up to about 10% of patients can develop it, so it's not insignificant. Next slide, please. What do we know so far, or probably better term is what is the terminology around breakthrough hemolysis? We describe it as either being pharmacokinetic or pharmacodynamic in origin, or the mechanism. So pharmacokinetic is slightly easier to explain. It's where the dose of the complement inhibitor drug is not enough to cover the amount of complement activity. So, for example, if you're on ravulizumab, a C5 inhibitor, every 8 weeks, and then as you're coming up to the 7th, 8th week before your next dose, if you get a rip-roaring infection, which put your complement levels up, that might then overwhelm any ravulizumab you've got left and lead to breakthrough hemolysis and hemolysis of the PNH cells. Pharmacodynamic is the opposite, really. It's where you've got, or you should have, enough of the complement inhibitor within your bloodstream to cover the amount of complement activity. So some patients still get breakthrough hemolysis even though there's no obvious infection. And those are the breakthrough events that are yet currently unexplained, and where my project will hopefully shed some light. Next slide, please. So this is the final slide. What am I doing? So currently I'm just collecting and freezing blood samples from 2 cohorts of patients, from well patients who've got PNH, who are coming to outpatient clinic. That can be any patient really on any type of complement inhibitor, including patients who aren't on any complement inhibitors. That's giving me a baseline cohort of patients. And then I'm also collecting and freezing blood samples from patients with PNH who are having events of breakthrough hemolysis. So this is from patients all across the country, all across the UK. If they present to their local hospital with signs and symptoms of breakthrough hemolysis, and the patients have been consented, then I will get some samples and I'll get them couriered down to myself in Leeds so I can process them. So I'm building up a database almost. Importantly to say, all patients must be consented to the PNH Research Tissue Bank for me to be able to use their samples. So this research project has been approved by the Ethics Committee of the PNH Research Tissue Bank, which allow me to collect, process, and then do further tests on them in the future. So what am I going to test? Once I've bought all my kits for the lab, I'm going to be comparing how different markers in the blood might differ between baseline patients and when patients then develop breakthrough hemolysis, and see if there's any patterns that we can find which might shed a little bit of light on what's going on. And that, in a nutshell, is my research.
Fabulous. Thank you so much.
Thank you.
So one of the things I would say about the research you just heard about is, although SEBI are funding it, they have no say in any of the day-to-day research, and they're not involved in the research questions that we're looking at. So the whole point of the research is to answer unanswered questions about what's happening in people who are on anticomplement therapy who get breakthrough, and so we can understand more about why it's occurring, so we can try to stop it happening, because the whole point of this is to improve patient care and improve our understanding of the disease. So I just wanted to add that.
Okay. You should be able to see the slides.
Thanks, Sophie. So I think this follows on quite nicely in terms of wanting to make sure we collect information about PNH in such an ultra rare condition, so that we can know as much about the illness as possible, so that going forwards we tackle the issues that are relevant to people who have PNH. Next slide, please. So a number of you will no doubt be in the current international registry. So and I'll talk more about that in a moment. Patient registries are important. They're especially for an ultra rare condition. They're a way of collecting anonymized information about people with an ultra rare condition, about their health, about their medical care, about the effectiveness and the safety of different treatments. And it's especially important when conditions are so uncommon. So it's easy to collect data about heart disease or diabetes or smoking, because there's lots of people who either have those conditions or who smoke. But collecting information about a rare condition is very difficult without something like a registry. Next slide, please. So currently there is an international registry, but the data is owned by a drug company. It's owned by Alexion Pharmaceuticals. It's been open since 2007, and it's currently open in 17 countries, and there's just over 1,900 patients who are actively being followed up in the registry. And in the UK, we have quite a lot of people who we've collected long-term anonymized data on, which actually has helped and made a difference. So one of the main benefits of the Alexion registry was the data that we managed to get published about pregnancy and about the safety of eculizumab in pregnancy, because previously around the world women who wanted to have a baby with PNH were actively told not to have a baby because of the risks with pregnancy. And because of the work we did in conjunction with the election registry, we now, around the world, eculizumab is offered, and we're generally able to help women through pregnancies. Next slide, please. And that's just one example. There are a number of new therapies that are either on the NHS, or we're hoping will be available on the NHS in the near future. So what we can't do is continue for one drug company to collect data on drugs that are made by other companies. And we also, as academics, we don't like the fact that the data is currently owned by a drug company. So so how can we address this? Well, we could have lots of different registries, but that's not very helpful. It fragments the data up, and it means we've not got a large repository of the data when we want to ask specific questions about PNH. What we have done is we have set up a new international registry, which I'm expecting will be available in the UK in the next few weeks to a small number of months. Next slide, please. So this is it is the IPIG registry. So IPIG is an organisation which is a non-for-profit organisation of academics around the world, so the IPIG registry is going to be open in 25 countries. It's purely an observational study, so it looks at what happens to patients in different countries. It'll, as long as people consent to being in the registry, we'll be able to answer questions about the effectiveness of treatments, what happens to people with small PNH clones. There's one of the questions that I was sent. Do we have any data on the number of people whose PNH clone has fallen below 10% and have stopped anti-complement therapy? So there's quite a lot. There's a lot of unanswered questions that a registry will allow us to do, and this registry is one where the data will not be owned by a drug company. Next slide, please. So IPIG, there are two committees. There's the main committee, which is the registry committee, and there's a second committee, the stakeholder committee. So the registry committee is made up of patient representatives from the Global Alliance. Maria is part of that, and academics from different parts of the world, and they that registry committee takes the decisions in the key decisions about the registry and about what information has been collected. We work alongside pharmaceutical partners because international registries are inordinately expensive. I hadn't realised how expensive until we started work on it. But so we work alongside pharmaceutical partners, and the benefit for the pharmaceutical partners is they will receive anonymized data about patients who are on their therapies, because they need to show the NHS, they need to show the FDA, they need to show the European countries that their products are safe and effective. Otherwise, we will not be able to have the treatments that we currently have and that we're hoping to have for PNH going forward. So the registry is a good way of collecting that information, and also information about the natural history of the disease. Next slide, please. So at the moment, these are the initial countries that the registry will be open in. We've got 114 sites planned in these different countries. In the UK, it's all the documentation has been put together. And we will. It's been submitted to ethics, and that's being looked at on Friday this week. Similar to the election registry, we will collect data on a 6-monthly basis in terms of what's happening to patients. It's all anonymized and will only for each of you that we approach, this is a voluntary thing to do, but it's useful to us as a PNH community to know more about what happens to people with PNH. So we'll certainly be asking you about this once we've gone through the ethics and approval processes in the UK. The other important thing that the registry is going to do is it will so one of the
I think addressing the ones that we've been sent through in advance, and if there's any that we were happy to take them.
I think we've covered most of these.
I think we've covered
within
yeah.
this. Yeah.
It may not be across the whole group. However, I'm keen to understand how many people are receiving the iptacopan tablet treatment, and how many people may have had suffered breakthrough hemolysis from that.
Okay. The iptacopan data is currently sort of published and been presented within the clinical studies, both at EHA and ASH. There was breakthrough events within the study. It was less than in the eculizumab cohort or the ravulizumab cohort. So yes, breakthrough does happen. It's a twice-a-day treatment, and I think it's too early to say whether it happens less frequently than on eculizumab or ravulizumab in a wider sort of real-world patient cohort. But the half-life of the iptacopan is about 18 hours, and so you know, you are getting a twice-a-day drug going in. So I think we've got patients on it within a managed access scheme and within clinical trials at the moment. We are expecting people to want to be able to access it when it's, well, if it's approved by NICE.
Okay, thank you. And the very last one was, could you please just circulate the link to the PNH explanatory video? I've possibly not seen that, and it may be a new one for me. So it'd be lovely if you could circulate that, please.
Yes,
thank you
of
very
course.
much. Thank you.
So just the videos on our website, so it's pnhserviceuk.co.uk, and it's within the patient information, but we can certainly link that in later.
Am I okay to answer that? So both the election registry and the IPIC registry will provide more information about that. What we know, so we looked just recently at all the people we've treated in the UK with eculizumab and ravulizumab over a 20-year period. So there are just over 500 people, and 20 people were able to stop eculizumab or ravulizumab because their PNH clone had dropped below 10%. Now, what I can't give you, because we've not specifically looked at it, is what proportion of people who've got a very gradually reducing clone size over time but haven't reached that 10% threshold. So because there's a number of people that we care for where the PNH level is gradually decreasing. But of the people that we've treated over a 20-year period, it's about 4% of people where the clone has dropped to a level where we're able to stop treatment. And by far the norm when it does that is it stays below 10%, and we don't need to restart. It's extremely rare for us to need to then restart anti-complement therapy. So what we would want to do is to do two different time points to where the PNH level is less than 10%. It doesn't need to be 3 or 6 months apart, but maybe at least a month apart. We would never start someone on anti-complement therapy with a PNH level less than 10%. And anyone who's got a PNH level, especially when they've had treatment, you're stuck with us. We'll keep interacting with you, and we'll keep looking to make sure that what happens to that PNH level over time. So if it were to go back up, it would depend on how much it went back up, and what symptoms you were having and what you needed. And I would expect as a service we would listen to you, and we would look at the bloods, and we would come to decisions with you in terms of the appropriate treatments for you. The important thing to be aware of is that when the PNH clone does drop down and we do look to stop anti-complement therapy, we do want to reassess your bone marrow. So there is to say someone has X or Y. So I would say, you know, you've got a very small level of PNH cells, but I wouldn't let it define you.
You've got silence, Sarah, because it's a difficult question to answer. So,
sorry.
I think I would say in general, we don't tend to see across the board an increased risk of infections in people with PNH. We do, if you're on one of the treatments just above on the proximal complement inhibitor scale, we do vaccinate people for haemolysis and pneumococcus as a precaution. I think if and I would say this about anybody, if you know you're getting recurrent infections, then I would be doing some more investigations just to perhaps rule out any other issues or causes. We know that ravulizumab blocks at the C5 level, and really the only thing you need C5 for is to mount an immune response to meningococcal infection, and that's obviously why we put all the advice and things in. So I probably would look holistically at you rather than just putting it down to PNH, but obviously you've personally noticed a change since you've been on treatment, so I would look at the whole you, not just the.
Okay, I'm very conscious of time. I know that there's been some other burning questions, but I feel that we need to move on to the next slide, Sophie, and just say thank you for all of those questions there. And I know that if there is anything, you feel free to get in touch with us if you want us to explore further, and we can do further meetings in more detail if to be guided by people's wants. But I think just to mention, there is the Super Rare campaign that I talked about before going on in the background, which PNH support is very much part of. There are online mindfulness courses that are going on. There's one that's just started this week, so there'll be another one coming up in the near future. And on the next slide, we have just to mention that there is a face-to-face meeting. Oh, I forgot to mention about the free benefits advice and the emotional well-being support that's available. All of this information is on the PNH support website. But also there is a meeting coming up that's a face-to-face meeting in London, but the venue has changed for that, just for everyone to note that is planning to go to that. It's now at the National Theatre, not the Hayward Gallery, both very nice places to visit. And that there is an East Anglia group, if anyone on the meeting today wants to join that group of people as well from that point of view. But I think in all honesty, it's just been nice to see so many people on the call today and to hear people's different questions. But I also think that, you know, the update from the service is keeping things going, and we know that there this kind of thing helps us move things forwards from our side, as well as hearing your voices. So do get in touch if there is anything, but otherwise let's end there, because I think we've completely gone over time already.
Yes, thank you very much, Louise. Just flashing up that next slide on the travel insurance webinar as well.
Okay, that's just come up for me.
On the 14th of March. And then a ending slide with a massive thank you, as you just said, Louise, to you, your colleagues, to the PNH support team. So Maria, Alex, Myra, Andrew, working hard behind the scenes, and to you, all of you, the attendees. And please watch out for a feedback form if you've enjoyed today's session and want to say thank you, or want to suggest some other ideas. Please do so. I'll be sending this out in an email very shortly. So absolutely, thank you very much to everybody, and have a lovely rest of the day.
Thank you.
Thanks,
Thank you
everyone.
all.